Okay, so whenever you want, I can start.
Yeah, so whenever you're ready, Paulino, to go ahead and start. Everyone, Paulino is going to share a very interesting case with us.
Okay, so let's start. Please let me know if I'm going too fast or you want any more data. Stop me whenever you want. So I first give you a one-liner. So this is a 64-year-old male, has past medical history of CLL, autoimmune hemolytic anemia. Sorry, actually, let me put the pointer here. I feel, there we go. Which is, you're gonna see abbreviated in the slides as this. A recent episode of cholecystitis that came to urgent care for jaundice and fatigue. Now going a bit deeper into the history. So patient 64 has past medical history of CLL. The CLL had been treated before with just observation, but he was hospitalized 3 months ago because of Lyme disease. And during that admission, he developed a pretty severe autoimmune hemolytic anemia. And because of that also, and because the CLL was progressing, he was started on steroids and rituximab. After that, he was discharged home. And a month ago, rituximab was replaced by ibrutinib. He was readmitted and discharged 10 days ago. So he was 3 days in the hospital and discharged 10 days ago because of a cholecystitis that was treated with only antibiotics. And since the episode of the severe autoimmune hemolytic anemia, he's been pretty anemic. Hemoglobin has been between 6 and 8. So he came to urgent care. So all the history I told you happened in an outside hospital. So unfortunately, we didn't have a lot of much data than what the patient told us. And he came to urgent care because he was feeling, he had the feeling he was having jaundice again, and he was having a lot of fatigue for the past 4 days. The daughter, who's very involved in her care, came with him, and she said that he had the same symptoms whenever the past times that he developed the autoimmune hemolytic anemia flares. And also when that happened before, he was also becoming confused. So she kind of told us that he looks exactly the same as when he developed these attacks of autoimmune hemolytic anemia. So now going more about the history. So I mentioned the past medical history of CLL, autoimmune hemolytic anemia, Lyme infection that was treated, a recent admission for cholecystitis. He also has a remote history of nephrolithiasis and tonsillectomy. It doesn't have a contributory family history. As a social history, he's a geologist. As I mentioned, the daughter is pretty involved in his care. He's a former smoker. He quit 30 years ago, smokes in all his life something around 5 packs per year. He drinks socially and he doesn't do any drugs. And again, feel free to stop me if anything is not clear, please. And now going for the medications and allergies. So he has no known allergies. And medications, he's taking prednisone 80 milligrams, ibrutinib 420 milligrams, vitamin B12, folic acid, and pantoprazole 40 milligrams. And I mentioned he's not allergic to anything. Sorry, I see something in the.
Yeah, so Frida is asking if he's compliant with his meds.
He's very compliant with all his meds, and the daughter is make sure he is.
At what stage of Lyme disease he was diagnosed and like?
That's a great question, but when we saw the patient, we have no records of it, so we don't know. Okay, sorry. So review assistance, and he referred weight loss for the past 3 months. He cannot really estimate how much, but he realized that his clothes are bigger. He refers some chills, but no fevers, and some fatigue. Sorry, see something in the chat. So he hasn't had any fevers, And chills, he referred chills for the past 4 days. So kind of when the symptoms started. And then the rest is pretty negative. As you can see here, I won't go one by point, but basically he complains about jaundice. And he also had an episode of blurry vision in the ED, but when we came to see him, sorry, in urgent care, but when we came to see him, he was already saying that it was gone. It was kind of a pretty brief episode. Sorry, pretty slow. And now going for the vital signs, he's afebrile, normal heart rate, normal respiratory rate, blood pressure is, as you can see, pretty good, 115/96. He's saturating a bit on the lower side, but still fine in room air, 94%. He is well developed. He's in mild distress when we saw him. He looked somehow sick. He has definitely jaundice and icteric sclera. Otherwise, the mouth was pretty clean. He did have some cervical lymphadenopathy. Sorry, see the chat again. So yeah, so sorry, Joe is asking if how the cholecystitis was treated. So they, again, we don't have the records, but what we know is that he was only given antibiotics. There was no surgery. We asked that several times and he said no surgery. No abdominal pain, to answer Frida's question, and to answer no, and we don't know the cause of the cholecystitis. Sorry if we don't have enough information, but that's how it happened in real time. And that was also a limitation in the evaluation of this patient. So I just want to make it how it was. So we see a cervical lymphadenopathy. We say actually bilateral. Sorry, I forgot to mention here. Heart exam is pretty unremarkable. The lungs are clear to auscultation. Abdomen is soft, normal bowel sounds, not tender, not distended, and pretty benign abdominal exam. He has some trace pedal edema, has jaundice. The neurological exam is pretty interesting. So we did a full neuro exam that was pretty unremarkable. We also evaluated gait. I didn't put it here. His gait was normal, but he does have loss of short-term memory. So when we saw the patient, he was alone. The daughter was gone, and he couldn't remember what just happened. And even we evaluated, we talked to the patient, and then we went to see him again, and he couldn't really remember as well, but he could remember past information of his life. So it was pretty, pretty focused on short-term memory. Yeah. Sorry, Rafa, you wanted to say something?
No, I think we should pause for a little bit. It seems like people have a few questions, so
sorry, I just wanted to complete that and then answer the questions in the chat. Sorry. Okay, let me see. So we start. Frida's asking, any new abdominal pain? No, he has no abdominal pain at all. He's not complaining about that, and the abdominal exam is benign. It's difficult in the chat, guys. Ask, Madeline is asking if the lymph nodes were tender. No, they're not tender. How long he was diagnosed with CLL? So if I remember correctly, he was diagnosed in July, and we saw the patient in January, at the beginning of January. The autoimmune hemolytic anemia was diagnosed 3 months prior to us seeing the patient. Now, Ariela is asking if he has asteriskics. No, he didn't have any. And Christopher's iPhone, not Christopher, but Christopher iPhone is asking if the acute hemolytic anemia was from CLL. Yes, it was presumed to be from CLL, but again, we didn't have the records, but that was the working hypothesis. So how did he get Lyme disease? That's a great question. We don't know. He's a geologist, so he does travel around from time to time. Frida, this is very funny to see the questions in the chat, guys. Frida is asking if new abdominal distension. No, the abdomen is perfectly clear. He's not complaining of anything in the abdomen. So the abdomen, both the exam and the ROS is completely negative. Any history of leukostasis? Christopher iPhone is asking. No history of leukostasis. Ariela is asking, where is he from? That's a great question, Ariela. So I don't know, to be honest. I know he's from the either New York or New Jersey, I think. So from my mind, nothing far from New York. But again, he's a geologist, so he did have to travel multiple times for his job, but nothing recently, because he recently changed to be more in a supervising position. So nothing in the past 6 months, but before, yeah, he had to travel always around the United States, never went to any other country. Let me see, any change? Noor is asking if he had any change in stool color. No. Carlos is asking if any bleeding on exam petechiae. No. Since he was recently started on ibrutinib, did he had any recent imaging? No, we don't have any recent imaging of him. Do we know if there is liver and spleen involvement? He mentioned, that's actually a good question. So he did mention he had a bit of splenomegaly in one of his previous exams. He couldn't remember. So this, just to put you a bit in context, this patient just presented to Sloan Kettering and was accepted that day as a new patient and was sent to the ED. So that's why we don't have any other records of anything else. The patient still didn't bring most of the records. So any rash? No, he doesn't have any rash. And why was he switched to ibrutinib? Full response. So that's actually a great question. And that's also something that it was not fully clear why he was switched. The patient and the daughter couldn't really explain that well. It seems that from what we thought, it was because the autoimmune hemolytic anemia keep getting worse and worse despite being on pretty significant agents. So they thought that was driven mainly because of the CLL. So that's why they switched from rituximab to ibrutinib. That's our working hypothesis. Again, because we didn't unfortunately get the data, the documents of the past medical records, we don't really know, but that seems to be the reason.
Great. I think we can move on. Otherwise, we'll
okay. Yeah. Otherwise, you're gonna kill me, guys. Okay. So okay. So that's when we saw the patient in urgent care, right? So we went. Again, you know, his urgent care, so we are kind of also the ED team in that case. So this patient didn't have any workup. We sent our workup and we went home. And then when we came back to get signed out the next day, which was, they told us that 6 hours later after we saw the patient, he became febrile. So he was 39.4 Celsius. Sorry, don't know how much that is in Fahrenheit, but it's a lot. And he also became hypoxic to 80s. And he required 5 liters of nasal cannula to achieve a saturation higher than 92, 93. And we were not there when that happened, but we saw the exam that was documented. The rest of the vital signs, except for a heart rate in the 100s, was unremarkable. And the exam that is documented was unchanged, except for coarse breath sounds bilaterally, and I'm quoting here what it was written, without any clear crackles or wheezing. So the rest of the exam otherwise is unchanged. I see there's one chat question. Yeah, thank you, Rafa, for putting that there. Okay, so and now we have this. Does anybody want to collaborate with the program representation? So kind of to make a little summary of who's the patient, what happened, what is a clinical syndrome here?
Yeah. For this to help them out, I would probably go back to the HPI, or at least like
sure.
skim through them.
Sorry, yeah. So yeah, here you have the HPI.
So any volunteers? Otherwise, I can volunteer someone.
Christopher Siphon can present the patient. We have a 64-year-old male with past medical history of CLL that was diagnosed 6 months ago, right? And then autoimmune hemolytic anemia that was diagnosed 3 months prior to presentation. Currently on ibrutinib, and recently medically managed for cholecystitis. Now presenting with changes in skin discoloration, jaundice, changes in his behavioral to mental status, and fatigue for the past 4 days.
Great. Yeah. Great. I put here another, but yeah, basically the same thing that you mentioned: 64-year-old male, CLL, autoimmune hemolytic anemia, recent episode of cholecystitis that came because of jaundice, weight loss, and fatigue. He was found to have memory loss, confusion, and lymphadenopathy on exam, apart from the jaundice, and he became hypoxic and febrile after the initial evaluation. I see another chat. Was it confirmed that it was autoimmune hemolytic anemia? Maybe babetosis, but where he had babesia. So the patient doesn't, I mean, he was told that the autoimmune hemolytic anemia was from the CLL, so that seems to have been diagnosed that way. He doesn't have any history of babesiosis that we know about. Sorry, and I don't know if anybody started to mention that it could be babesia. If anybody has now, and again, we only have the HPI and the physical exam, so still we don't have the full picture here, but if anybody has any ideas for the differential diagnosis.
Hey, so the problem here is like jaundice has a really like wide differential diagnosis, and we need to know, is it like hemolysis or like liver related? So maybe some labs would help first to guide us, but it's really
Perfect. So which labs do you want?
So at least CBC to see his hemoglobin. We need the indexes as well. We need LDH, haptoglobin, reticulocyte. We need LFTs. And for like the workup for the fever as well, just to make sure it's not like cholangitis or like cholecystitis again. What else? Like chest X-ray, blood cultures.
Okay.
Would you get any abdominal imaging, Nor?
Yeah, I mean, if it's liver related, I would definitely get like at least ultrasound in the ED just to see his gallbladder and the common bile duct. Maybe he has like lymph nodes around the common bile duct as well for external like stones from his. I'm not sure if he has stone, but like usually hemolytic anemia can cause like small stones that can do recurrent like a cholecystitis or cholelithiasis and cholangitis like as a complication. So definitely we need that. But that depends on if it's like liver related or lysis related.
Nice, thank you so much. Let me see what we have in the chat. Oh, sorry, that went away. If we know he had gallstones, no, we don't know, unfortunately. Frida will be worried about cholangitis versus progression of his malignancy or worsening autoimmune hemolytic anemia. I think that's very reasonable. And she wants a blood smear. We'll give you a blood smear. Joe wants imaging. We'll give you imaging. Tomo thinks it may be an opportunistic infection. I don't know if you have any specific suggestions of what to look for or what kind of infection. Athena wants to get a CT head because of altered mental status and memory loss. Okay.
I think that's a very, very good point in regards to the opportunistic infections. Like we mentioned the cholecystitis, we've mentioned the autoimmune hemolytic anemia, but these patients can be very tricky because at baseline with CLL, they're already pretty immunosuppressed. And then you add like many different regimens and medications. So it can be like many different things. And I think we haven't mentioned that much like the hypoxemia as of now. Like, I mean, Nor definitely worked it up with a chest X-ray, and we are thinking of other things. But this patient might have more than one condition, and like we definitely have to do like the thorough infectious workup and like keep our differential broad, and especially for opportunistic infections, like Tomo said, in a patient like this.
Especially also that he has like this sudden desatting. I would also like, beside the parenchymal disease, I would just, he would at high risk for PEs as well, giving his history of like malignancy. So we need to maybe study.
And, sorry. And I was also thinking possible, I mean, in the setting of autoimmune hemolytic anemia, and this sort of episode where he was having the visual disturbance and his altered mental status and maybe a PE, you might think like a hyperviscosity syndrome. So if he also had one of those like cryoglobulinemia things, and if he had jaundice, if there's HCV as a possibility as one of those infections that could cause that. So
yeah, I mean, I think those are all great points. Definitely less likely with CLL as opposed to something like AML or like in terms of leukostasis, but definitely like, I mean, we need to, like I said, keep our differential broad for now and try not to anchor on a specific diagnosis, especially in a patient that already comes from prior hospitalizations, and you might think like, oh, it might be this or that was already mentioned in the chart. So just a bias that we always need to be careful of.
Okay, so also in the chat they're suggesting TTP as a possible diagnosis.
Dr. Perulini, you wanted to say something? Sorry.
No, I thought that Ariela's point was, was excellent. We don't have much information on his CLL, but, and we would think that if he got treated, then his numbers went down. But sometimes you can see this also, not only from proteins, like Ariela mentioned, but also from white blood cells. When you have an incredibly high number of leukocytes, you can see clogging of the capillaries, and that can give you the visual disturbance. It can give you the change in mental status. So I thought that Ariela's point was really excellent.
Agreed. So yeah, I think we can move forward with the data, Paulino.
Okay, perfect. So, well, we already talked about labs or imaging. And so let's see what we got. So here you have the basic labs. The numbers that you see in bold are the abnormalities. So it's a bit easier to everybody. This is absolute neutrophil count. I can actually comment on that. So you see the white blood cell count is elevated. And if we go on the differential, the ANC is elevated. So he has 14,000, almost 15,000 neutrophils. So these are definitely neutrophilia. The absolute lymphocyte count is a bit low. It's in the 400. He's also anemic, 6.8. His hemoglobin. MCV is 119, so microcytic anemia. Platelets are normal. You ask for a hemolysis lab, so haptoglobin is basically undetectable. LDH is high. Red count is also high, 372. Fibrinogen is also high, 497. The CMP is pretty unremarkable, except for a total Billy of 4.1, which is elevated, with a slight elevation on direct Billy. Coags are normal. B12 is high, more than 1,000, and BMP, troponin, and lactic acid were negative. See in the chat. So liver is innocent. Okay, and just to show you the rest of the labs, COVID-19 was negative. Respiratory biofire is negative. Hepatitis A, B, and C serology are negative. And just giving you the labs that we got the next day, right? So of course, like there's things that are gonna take more time. Procalcitonin was 0.17. Ferritin was high, 503. Iron, 58. IVC is high, 186. Transferrin saturation is 31. Galactomannan is negative, and beta-D-glucan is more than 500. It's positive. And just going for more tests, you also asked for a blood smear, which was unfortunately unremarkable. So no schistocytes, no parasites. Also, there were not any other findings. We did a UA that was unremarkable, and the EKG also was pretty unremarkable. And should I proceed with the imaging, Rafa?
So anyone have like any changes in their differential diagnosis with the data that we have? Any comments, anything that caught your eye?
Do we have comps? Do we have comps?
Coombs, no, we don't. Well, we sent it, but it just didn't come back yet.
Okay, yeah, I think we can proceed with the imaging.
Okay, so we did an X-ray. I can show you here. I don't know if anybody wants to read it.
Anyone brave going into palm? Let's see. Yasmin, would you want to take a stab at it?
Sure. So we have this chest X-ray, and we can see. I mean, I'm gonna go directly to the lungs because we can see that there's no effusion, but he does have some. I want to call it hazy opacities, maybe just increased vasculature, bilateral, and closer to the hilum, I would say. Probably yes. Fluid sounds like looks like vascular congestion probably because it goes to the upper third of the lungs bilateral. Yeah, basically.
Okay. But here I think also they were saying in the chat also that they also thought it was edema. So we see, I just put here the reading, the conclusion, but basically says bilateral airspace opacities, either pneumonia or edema. So I see another question in the chat. And a fissure with fluid. Oh yeah, definitely. Didn't see that. Then we so because we couldn't really identify, so we were actually concerned about the abdomen, right? About why, because it was a bit unclear to us what happened with this cholecystitis, because as you can see, we didn't have a lot. So we was kind of discussing with Sen, and we actually pan-CT him. We did a CT of the chest, abdomen, and pelvis, that you can see here. Also, because we were not really sure about this edema when the BNP was negative, a patient that didn't have any cardiac history. And that's what we saw. I just put two of the images that I think are representative. I don't know if anybody wants to make any comment on what you guys see on the CT. If we see any cyst, no, we don't see, well, I didn't see really any cyst. I don't know if anybody wants to comment on the CT.
Ground glass opacities bilaterally, like asymmetric. I just have a question, like there is like a nodularity around the bronchioles.
Well, let me tell you, that is a perfect reading of the CT, because this is the two findings he has. He has bilateral ground glass patchy opacities. This is literally textually the report, with multiple scatter pulmonary nodules and small bilateral effusion. So exactly as you mentioned, so we have ground glass patchy opacities and multiple pulmonary nodules. And also we also included, I didn't put it here just not to put too many images, but he also had a distended gallbladder with wall thickening that was consistent with either an acute or subacute cholecystitis. Is probably the cholecystitis that he had. We know that he had already, but it was still like look still inflamed as acute or subacute in the CT. And I put here another image where you can see quality is not so good. Sorry for that, but you see here the nodules here a bit better probably. And now I think also you mentioned already. I think I mentioned it to do a CT of the head because of this blurry vision. So we're pretty concerned also about that and about his loss of memory that was so peculiar. So we did a CT of the head, and I don't know if anybody sees anything here. I mean, honestly, I can probably put it from the beginning, but the radiologists realized about these things. I don't know if you see them more here. Which they report. I suspicious hypoattenuating lesions. I show you the 3 ones that are more clear, but there were at least 4. And they say that it's possibly malignant, but you know how they have this protocol to read the CT scans in Sloan probably means, I think, like a 50 or less % of possibility. So kind of open, like they don't really know what's that. I see something in the chat. Noor says that we need contrast CT head or an MRI. Okay, so if that's what you want, we will do it. So we did an MRI of the head because we were pretty concerned about these findings, and that's what we saw. You see there, the findings pretty clear. And now they say, so yeah, sorry.
I know that I was going to say the ring enhancing lesions, but you already put the report.
And you're a radiologist. So yeah, definitely. So yeah, exactly. So there are multiple ring enhancing brain lesions with mild edema, and there are probably abscesses, although they still kind of fully rule out metastasis, but it does seem that we are dealing with brain abscesses. So now that I gave you so much data, I don't know if anybody wants to do another problem representation now with all the data that we collected.
So Ariella, you want to go?
Do I? Okay. Sorry, 64-year-old man? 65. Okay. History of CLL treated Lyme disease and cholecystitis, not surgically operated on, coming in with jaundice, found to have hyperbilirubinemia and leukocytosis with high neutrophilic and high neutrophils. Also found to have ground glass opacities on CT and ring enhancing lesions. Am I doing the differential as well, or just the problem?
Oh, you can. I mean, you can say is there any differential that you're thinking about, or even some more data that you want to see?
More data that I want to see, or
like any more imaging, anything else? I mean, but you can start with the differential, and based on that, we take it from there.
Okay. Oh, okay. No, I think the differential is very long still for me, or I mean, it could be either like we were saying, infection versus malignancy are the highest ones, but I don't know if I can be more specific than that. Okay,
that's fine. I see in the chat they're saying that the altered mental status due to the enhancing lesions, acute cholecystitis, hypoxia because of lung edema, anemia because of the CLL, and stable ground glass opacities. Okay. But yeah, definitely. Thank you so much for the problem representation. I put here another one. So as you mentioned, 64-year-old male, CLL, autoimmune hemolytic anemia, recent cholecystitis, came with jaundice, weight loss, memory loss, fever, and hypoxia and fatigue. Found to have hemolysis. I think with the labs that we saw, we can already say that he's hemolyzing, right? Haptoglobin was undetectable, LDH was high, ground glass opacities and pulmonary nodules. The non-cholecystitis we saw also in the CT, and ring enhancing brain lesions with positive beta-D glucan. So I don't know if anybody at this point has any other differential diagnosis or any other things you want to do to get a diagnosis.
Can we send more labs?
Yeah, we can send all the labs we want.
Was a fungital sent?
The fungital is positive. Yeah, the beta-D glucan was positive.
Okay.
So I will send HIV, testo, crypto, and blasto serology, fungal culture, fungal blood culture, and we can send respiratory bacteria and fungal culture as well.
Okay. Okay, perfect. Sorry, what did I miss that one? Can you? Okay, well, in the chat, I see if we have blood cultures, we send them. I'm going to show you the results now. Tomo is suggesting to the bronchoscopy. I like that one. Raul says it's either PCP infection versus toxoplasma. That's a very nice idea. Versus ibrutinib-induced pneumonitis. Nice. Cryptococcus. Okay, I'm gonna show you now in the next slide the cryptococcus and the quantiferon too. LP, I also gonna show it to you. Blood gas, that's a good one that I didn't put there, but basically lactate was negative, PCO2 was unremarkable, and we did a VVG, we didn't do a AVG. And a TT Fatman ones, I will also show it to you in the next slide. Okay, any differential diagnosis you're thinking about? Well, Socratic wrote Cryptococcus, okay? Okay, I like that. So a lot of nice suggestions. Okay, so let's see what happened with this patient. Okay, so after seeing that the cholecystitis was still active, he got a percutaneous cholecystostomy. That was, to be honest, a bit controversial because there was a bit of mixed opinions whether that was actually the source, but because we had doubts whether the patient had actually completed the course of antibiotics, we ended up doing that. The bile duct culture gram stain was negative, but his mental status continued to get worse, and the brain lesions increased in size, and the respiratory status worsened also. So at that point, we actually decided to do a bronchoscopy, and because the abscesses were getting bigger, neurosurgery was consulted, and they recommended to drain at least one of them to get a micro biological diagnosis, right? So now this time all the tests that you asked for came back. So basically Lyme was negative, but I'm talking about the PCR of Lyme. Babesia was negative. Blood and respiratory cultures were negative all the time. Legionella negative. Histoplasma was negative. HIV negative. Blastococcus, anaplasma, and toxoserology were all negative. Crypto, I think you also mentioned, was negative. PCP of the sputum was negative, and I have to say we really thought it was a PCP because I don't know if you went back to see. I can actually show you the medication of this patient, which is something that I found pretty was at that point our main differential. So this patient was on 80 of prednisone for 3 months. He was not on PCP prophylaxis. So at the beginning, when he presented with this X-ray and fever, we thought he had PCP, but he didn't. But just to mention that he was not on PCP prophylaxis, which was something he should have been. CMV and EVV IgM were both negative. So we did end up doing the bronchoscopy that showed Aspergillus fumigatus, and the brain abscesses were we got an aspirate that shows Aspergillus fumigatus with tissue invasion. So the diagnosis was diagnosed with invasive aspergillosis due to ibrutinib. So he was treated with amphotericin B initially, and then we switched to micafungin and voriconazole. The pulmonary lesions improved. We weaned him out of oxygen. He had to be intubated at some point, but he was extubated and off oxygen, but the brain lesions improved only slightly. The mental status did not really, so I told you that it got much worse. It didn't really get any better, even that the brain lesions were getting slightly better. So at the end, there was a family meeting, and the family basically was discharged to hospice, and he lost follow-up. So we don't really know what happened. And also, I'm just going to put at the end of my presentation, because we did some more tests. We did an LP to have here the results. We even sent an LP, we sent a PCR for multiple viruses that were negative, even a flow cytometry for tumor cells. More labs that you see here. A TT that we also did that was negative. So just to talk a few words of aspergillosis, because it was something that we honestly didn't expect it. So you know that aspergillus can cause 4 types of disease. And the ABPA is basically asthmatic patients that have recurrent infiltrates and presents with worsening asthma and brown mucus plaques, right? We treat that one typically with steroids. Probably one of the most frequent ones. You also have the aspergillomas. There is basically a colonization of aspergillus of previous lung cavities, where you basically have this fungus ball that typically changes with position and can either be asymptomatic or produce hemoptysis, as they mentioned in the previous talk. It also can give rise to aspergillus, can also cause sinusitis. And as in this case, it can cause invasive aspergillosis, which is very typical in neutropenic or immunosuppressed patients like this one. It's typically only the lungs, but it can also affect other organs. And I'm going to go a bit deeper into invasive aspergillosis. And I really like this scheme from the clinical problem solvers. So first of all, we only have, there's some case reports, but mostly we have invasive aspergillosis in patients that are severely immunodeficient or have neutropenia. So remember, this patient had been on rituximab, was on high-dose steroids, has CLL, which by itself is a cause of immune suppression, and was on ibrutinib, had a lot of reasons to be immunocompromised. He presents with fever, can give hemoptysis or pleuritic chest pain, with cough and shortness of breath. This patient actually, we only had fever, and he did develop hypoxic respiratory failure overnight, but it was actually pretty curious that he presented just with altered mental status. And the differential diagnosis, we always have to think about also mucor in these patients. And you have here the classical questions, right, of different, aspergillus have septate, hyphae, mucor doesn't, and also the angle matters for them. And the pathophysiology, aspergillus is basically present everywhere. So we all breathe in aspergillus all the time, but because we're not immunocompromised, we don't develop disease. And the most common is Aspergillus fumigatus, as in this patient. And remember, very important for diagnosis, that because Aspergillus is everywhere, just the isolation of the of Aspergillus itself is not enough. We need to have the organism right and the right clinical context. So in this case, apart from having the Aspergillus, we have histological evidence of tissue invasion. And we also have it present in the bronchoalveolar lavage and in the biopsy. And we have these 2 markers, the beta-D-glucan, also known as fungitel, that is not specific to Aspergillus, so it can become elevated in any fungal infection. We do have the galactomannan antigen that is specific to Aspergillus. In this patient, it was negative, and I'm gonna comment in the next slide about their sensitivity and specificity. And in imaging, typically in CT, what we see is pulmonary nodules with ground glass opacities with this halo sign, and that you see here, that is kind of not fully like that, but we kind of saw it in the CT here, right? You have a nodule and you have some ground glass opacities around. But yeah, I guess that's difficult to see that the radiologists didn't really comment on that as and the first line treatment is voriconazole. And I see here a lot of questions here. So yeah, galactomannan was negative and fungitel was positive. I can show you again. Switch to Android. So I'm gonna go back again just to show you, just to avoid the confusion. So in this patient, oh my God, I like animations too much. So yeah, you see the galactomannan was negative and beta-D-glucan, the fungitel, was positive. Okay, so and just to comment about more things about invasive aspergillosis. So galactomannan has a sensitivity of 78% with a specificity of 85%. That of course depends on kind of the value that you use as a cutoff, right? So that can change, but as you can see, it's not 100% sensitivity as any of the tests. And it can also be elevated in other 2 infections, in Fusarium or histoplasma. There's always this thing that that people will tell you that if you give a patient Zosyn, that can increase galactomannan. So that is not true anymore. So Zosyn used to be prepared with all preparations of Zosyn could give you elevated galactomannan, but not anymore. There's actually a study if you are guys curious about it. But yeah, fusarium isoplasma can also elevate galactomannan. Beta-D-glucan, the fungi gel, can actually be more sensitive than galactomannan. Again, it really matters which value you use for cutoff, but it's typically more sensitive. And we saw that in this case, right? We have a positive beta-D-glucan, but negative galactomannan. And the treatment for this, apart from voriconazole, you typically do surgery. You try to address the reason why the patient is immunocompromised. And apart from voriconazole, you can add echinocandin if you want. The thing is that at the beginning, where you're not 100% sure if the patient has Aspergillus or mucor, the problem is that voriconazole doesn't treat mucor. So mucors are intrinsically resistant to voriconazole. So that's why also this patient got at the beginning amphotericin B, because amphotericin B treats both of them. And once you get the confirmation, you can switch to voriconazole and micafungin in this case. Sorry, and just some words about ibrutinib, because I mean, and I know it sounds like a weird therapy, but you guys know CLL is very common. These TKI inhibitors are getting more and more common, and it's very likely that you're going to see this regardless of what specialty you do, just because of how prevalent is CLL. So ibrutinib is a BT, inhibits the BTK, basically is a TKI inhibitor, and is very used in CLL, and it's also used in other malignancies. And you're probably going to deal with the side effects of ibrutinib a lot, because as you can see here are pretty peculiar. So one of them is hypertension. So around 17% of the patients that get ibrutinib have hypertension. And other ones that I want to remark is atrial fibrillation. So actually 8% of the patients that take ibrutinib develop atrial fibrillation or atrial flutter. And also they have increased rate of bleeding. So it's actually a nightmare, because they develop the atrial fibrillation, and you always have the question whether they should be anticoagulated or not. I think there are some guidelines about that. This still makes sense to anticoagulate them, but you have to be very careful because they have an increased rate of bleeding. And this also put all the other side effects that it has. But also there is an increased rate of infections, such as sepsis, PCP pneumonia, but also, as in this case, invasive fungal infections. And it's very typical that they develop aspergillosis affecting the central nervous systems, especially if we use them in high doses, or if the patient has any other reasons to be immunocompromised. So I just show you this publication here that basically analyze a cohort of patients that develop invasive aspergillosis with ibrutinib. And yeah, as you can see here, I mean, basically having any other cause of immunosuppression apart from the CLL was associated with an increased rate of aspergillosis. And it's actually pretty curious that they develop cerebral locations in 40% of the cases, which is actually a lot, that's actually pretty uncommon. So just finishing up with the take-home messages, if you have a patient that is immunosuppressed, have a very high suspicion for fungal infections. That goes for patients on CLL, but also patients that have high-dose steroids, are taking rituximab, or have neutropenia. Also remember, every time that you see a MET-REC with high-dose steroids, you should see PCP prophylaxis. And that is a very important thing. This patient was on 80 of prednisone for 3 months, and nobody put him on PCP prophylaxis. And also, if a patient is taking a medication that you're not familiar with, look at the side effects. So, you know, when I took this patient, I had no idea it was ibrutinib, but we quickly look it up, because I mean, some of these, this is just one of the multiple examples. Some of these new therapies have associations with diseases that are very uncommon, and you know, oncology is going to keep advancing, and they're going to keep coming more diseases. So I think always up to date in, you know, the kind of therapy that they're taking, to make sure that there's nothing, you know, that you should be expecting with it, I think is very important. And not all the tests, like in this case, the galactomannan, are 100% sensitive or 100% specific. So this patient had a negative galactomannan and still had an infection with Aspergillus. And oh yeah, Dr. Sawyer, right there, when do you have to PCP prophylaxis? And yeah, that's all. I don't know if you guys have any other questions or any other comments.
Yeah, thank you so much for that presentation, Paulino. It was an extremely interesting case. I would say that point number 3 is extremely important and also goes with number 8, right? I would say, like, when thinking about immunosuppressed patients, not thinking like, oh, it's immunosuppressed, like not everyone fits in the same bucket. Like, different medications predispose you to different infections. And I'm actually really quickly gonna share my screen. It's actually just a table from like up to date, meaning like going over the different prophylactic regimens for CLL. And actually you can see that, I mean, initially CLL by itself, it's a condition that makes you immunosuppressed. But if you look into it, sure, it affects cellular and humoral immunity, and it predisposes you to traditional, like more common infections, I would say, like strep, staph, like stuff that you would expect a little bit more. But as chemotherapy has advanced, these patients start on treatment and then become predisposed to like many different infections, to the point where like some patients might require like HSV, VSV prophylaxis as well, like viral, not just fungal. And like some, for example, here alemtuzumab, you see that marker says like if you give steroids, then you should consider maybe antifungal prophylaxis. And I think that's why I think that point you make is like both with like some specialties like rheum, like onc that use immunosuppressive therapies that we're not familiar with, it can be a little bit intimidating. But just by looking it up, like you said, I think that's extremely beneficial for the patient and might completely change, do a 180 on your differential diagnosis and workup.
Yeah, and sorry I missed the case. I have a meeting at 4, so I try to join when I can come back. But I think from the last few slides, you did a really great job, and it's correct. Like the thing is a lot of these new drugs, like you mentioned, you know, I sent the 2 different articles. One is an actual published article, but the other one's just a report about how, like in the last year, 3% of people who are on these medications have shown up with invasive, you know, aspergillosis. So these are the things that, the nice thing is we have access to the internet, and the nice thing is that you could, if something doesn't fit, like I like that specific teaching point, if it doesn't fit and you feel at all, I always err on the safer side. And I'm glad that you brought up the whole mucor versus, you know, aspergillosis, because then the treatment is different. And we always get asked, why can't you just put a cytokine? Why can't you just do an azole? Well, there's a reason, because certain things don't cover, and you want to be as broad as you can in the very beginning. You can always narrow it as you get more information. And then the other teaching point, yes, labs don't always are not always your thing that you rely on. Just because something's negative doesn't mean that you rule it out. So there's multiple cases where I've been on consults where we keep something on because of the clinical scenario. And as this time goes on and we wait for more information, then you stop it with the understanding that people are managing it. You're just not leaving someone on their own on Amphil, what have you. But yes, everyone should be aware of these, and it's as easy as you just basically Googling, you know, nice thing is there is Google. You don't have to go to the library anymore, and be able to look these things up and see. And that's kind of the nice thing about medicine and the detective work that we do, just to kind of make sure that we don't narrow and anchor on things right away.
Yeah, what I would say is, well, thank you, Paulino. It was a great case. And from what you are showing, it looks like we are more and more likely to see patients like this one, in the near future. Yeah, I think it was also great to hear everyone's participation, because I think all the questions, all the comments were really, fantastic. The other thing that I learned a lot from the case, and for me, what was good was to see that on the differential you had mucor as one of the main differentials, because as you were going through the case, this patient clinically really looked so much like 2 patients that I saw in the hospital with mucormycosis, and actually the patients that I saw did have endocarditis with brain abscesses, but the differential was, the clinical presentation was almost identical to this case. And something that I remember from mucor was something that you need to get from the history, which is that one of the risk factors to develop infections by mucormycosis is prior exposure to chelating agents. And the patient that I saw actually had a history of having received deferoxamine for some reason that I don't remember. But in his case, the diagnosis was really postmortem. It was in the autopsy that we found the mucor in his brain. But the clinical presentation was, just very much like this one. So yeah, thank you, Paulino.
Thank you.
I'm more bummed that I missed it, but yes.
Yeah, no, thank you so much, Dr. Paulino and Dr. Sora, for your contributions. If there are no more questions, I don't see any further ones in the chat, then I think we can call it a day. Again, thank you so much, Paulino. Excellent work.